Good morning, everyone. This is Lana Comstock. I want to welcome you to the Opioid Guardianship Take 2 results. So you know that I am an employee here at IHC, and most of you know that I work with the Compass HIN as a community health consultant. I've been responsible for the HIN opioid project for the past few months, and so today I have the opportunity to provide you with our project results. I am recording the webinar today, so just a few reminders as we prepare to get started. Just make sure your telephone and your computer lines are muted. I did set it up so it would be muted throughout the joining, so we shouldn't have a problem today. And I also just want to remind you to please go ahead and utilize the chat box so we can have some conversation. So as questions come up or comments, I will go ahead and address those throughout our presentation today. So I'd like to make sure to thank each and every one of our participating hospitals, the project leads, the sponsors, as well as the opioid stewardship teams who worked so hard to achieve the project goals for the opioid guardianship project. I'd also like to extend a sincere thank you to so many people here at the Iowa Healthcare Collaborative, the employees who provided support throughout this project, and some specific people that I'd really want to recognize include not only my HIN team here at IHC, they've just shown ongoing support of this project, but additionally Sarah Durr, who's our medication management pharmacist here at IHC, for all of her expertise in sharing the legislative updates, the assistance that she provided in obtaining quality speakers for our presentations and our continuing education, our webinars, and just all the work behind the scenes that Sarah has been so engaged in as we work to assist all of our hospitals in this project. I'd also like to thank the data team for the support that they've also shown, and a special thank you to Bobby Brummel, data analyst, who worked to develop all of those HIN opioid overview reports, the hospital-specific reports for each of you, and just providing the data that we are actually using in today's presentation as well. And finally, I'd like to make sure to recognize the original developers of the Iowa Healthcare Collaborative HIN opioid project, to include the development of those comfort tools that we have used. A big thank you to Brian Isett. He's IHC faculty for medication safety, and Jennifer Kriegmer, a previous IHC HIN improvement advisor. You know, honestly, without their work on that first project, and then Jennifer's work to organize this second project for our HIN hospitals, we wouldn't have had the learning and the rapid cycle process improvement to the opioid stewardship program that we have been developing. So sincerely, a big thanks to everyone. As we got started with our Opioid Guardianship Take 2 project, it officially began on January 5th, and with that was a pre-survey that was completed. And initially when we got started, we had 45 hospitals who had actually committed to participation in the Opioid Guardianship project. However, during the course of the project, there were 7 hospitals who did withdraw, and that was for various reasons of why they had to withdraw from our program. Upon conclusion then with the project, and you can see here, we essentially had 37 hospitals left. 2 of those were in South Dakota, and the remaining hospitals were in Iowa. Of the number of participants that we had in the Take 2 project, there were 9 hospitals who actually had participated in the first opioid guardianship project. So essentially, a quarter of our participants in Project 2 were also engaged in Project 1. And there were some huge successes that we learned from having those hospitals who participated the second time. So we have a few pieces of information that we'll share throughout. I'd like to ask those hospitals that are on today that participated in that first project, feel free to type in, even if it's a 1 or 2 sentence notation about what was great for you in participating 2 times in the opioid guardianship project. So next, we're going to take a look at really just a review of what our project focus was. So the overarching goal of the project was to utilize a multidisciplinary team approach to implement safe and effective use of opioids in prescribing, while we also work to reframe pain to focus on comfort, using the comfort tools, as well as keeping that focus on patient and or family engagement in the process of the work that we did. So the participation commitment to the project started with identification of the project leader and then identification of an executive sponsor to support participation within the project. So we had timelines on all of that to happen. The next steps were to begin assembling your opioid guardianship project team, which you'll hear me interchange for opioid stewardship as well. So we had to get your team together, and we wanted to make sure that they were there to assist you in the facility in successfully completing the action-focused phases throughout this project. One of the recommendations that we did make was to hold a team meeting at least every other week. And I think that people started initially with weekly meetings, and then it was kind of individualized by the hospital. Some continued to meet on a weekly basis, others went to the every other week, and also as needed. A big part of the commitment as well was to assure that we had self-reported data within the HIN database around our ADE measures. And so that was being done, as well as other commitments for pre and post surveys. We had some cohort sharing, and there was a lot of sharing, successes as well as challenges with cohort colleagues throughout this project. Sometimes it was done just via emails, it was done in our Q&A calls, and oftentimes there might even be a conference call where we had different assistants and people helping and supporting one another. So there was so much sharing that was happening. That was probably the one biggest takeaway that we have gotten feedback on from participants, was that was what really helped the teams in the individual hospitals in moving forward. And I think sometimes, you know, it helps when you can recognize there might be some like commonalities of struggles, as well as that sharing that can happen when there are successes in those small takeaways. So the other commitment piece was webinar participation. We had 4 mandatory webinars, and we wanted at least one team member for your opioid stewardship teams to participate in those. And then we wanted the utilization of the comfort scale in a sample population minimally to participate in the required research study that we were using during this project. And then the last major focus was for you to provide community outreach on the safe and effective use of opioids. So some of those benefits to participation was the education that was provided to healthcare providers on evidence-based best practices and emerging new resources. You got a resource flyer. It was provided, and it included controlled substance disposal sites, treatment centers, as well as locations for naloxone standing orders and where those participating locations were. Again, we talked about the peer support and sharing that occurred, and there was much done with developing opioid treatment plans, much sharing. We had some virtual coaching from pharmacists as well as quality improvement consultants, and then data analysis that you got reports from the Healthcare Collaborative. And then also some multidisciplinary evidence-based practices that were and emerging new resources that were provided throughout this project. And honestly, it was just kind of overwhelming sometimes because of the amount of new information, the new resources that are still ongoing and keep being developed. And so we want to share as much as we can so you have opportunity to take a look at what might help in your facility the best. And as you know, there is the comfort research study, and so there'll be some data analysis related to that. And the other benefit is national recognition. And you say, how? Well, nationally being recognized, hopefully from a publication that'll happen from our study. And secondly, we are taking this information to CMS. We have some leadership here at the Healthcare Collaborative that'll be presenting information about this project in Maryland to CMS. So that'll be the national recognition. So project participants assured the data tracking for the components of what their hospital was implementing, so we could have some comparative rates for our adverse drug events measures to include the ADE rate, the opioid therapy treatment plan, stat naloxone administration in the inpatient population, and then stat naloxone administered in the emergency department. And reporting of stat Narcan in the ED was highly encouraged. And I'm going to show a slide upcoming that'll show kind of what was happening with the participants in our project and versus all Compass 10 hospitals that are currently reporting. And then the community meeting. Participants were provided with a standardized PowerPoint, and it was a template, so it could be personalized to the hospital, to the community, to present information about the opioid crisis, to begin or to continue to build community commitments in partnering with the work within your community to raise awareness, provide education, identify priorities, and develop strategies on what the community could work on to combat the opioid crisis within your own individual communities. And I think that people were very appreciative of having those templates. Another piece that was provided was the hospital resource specific to opioid resources. This is an example, as you see, at Buena Vista. And so the hospital-specific resource flyer was provided to everyone. You all had your own individualized flyer. They are editable should there be any updates that you'd like to include within your community. But it shows not only the hospital name, but the drop-off site, standing naloxone orders, and also information about the Iowa PMP in that website. You received opioid reports, and this is just kind of a jumble of the different pieces that you received. So there were opioid reports, there were data dictionaries and opioid ICD-10 code listings, and every hospital got that. In addition to receiving a full-length opioid overview report for our Compass HIN, and that data was January 2016 through December of 2017, each hospital received its own specific opioid report. And utilization of the report is done in conjunction with the opioid ICD code listing, the data dictionary that was provided, because using those together helps understand what's happening within your hospital-specific report. We did have an overview review of the reports in our Q&A call on June 5th. And so that training call was actually recorded, and it can be found on Innovation. So we're going to move into the post-survey results, and let me just do a quick check to see if we have any comments at this point or any questions. In our post-survey, there were 24 participating hospitals that actually completed the post-survey. And just over half of our participants have completed a community meeting and provided education about the safe and effective use of opioids. So 52% is what you'll see. And the question here was, during the project, have you provided education to the community about safe and effective use of opioids? So note that we have some hospitals who still haven't done that. And of those remaining hospitals who haven't yet achieved the community meeting, they all have established an upcoming community meeting date. And some of the hospitals who still have to do that, as well as those who have held meetings, either did a special community meeting, or others, they actually use their community coalition meetings that are already in place. While even others utilized a special opioid task force meeting that maybe it was already in place or just getting started to discuss the opioid guardianship project and provide the community education from the slides that we did provide to our participants from IHC. So we also wanted to know about that facility education that was provided to healthcare teams and prescribers. And so you can see here 95% of our participants did provide opioid education to prescribers and healthcare teams during the project period. And this next slide actually shows what disciplines received the education during the project. And the number one here is at the top, showing nursing with a 96% response of nursing being provided education around opioids. Then we have prescribers, opioid prescribers, as well as pharmacists, who were at 92%. I was pleased to see the administrative team was there, as well as the board of directors, and we had a /governing boards depending on the type of hospital. And so that is key. We need to remember that that is where we get the support that we need to move our opioid stewardship projects forward. I was extremely pleased to see that we also engaged our other healthcare services to include physical therapists, occupational therapists, social services, and even lab. When I took a look at what other were, it was any of those other support staff within healthcare. So we have a lot of those. So I think we're doing a good job in making sure that our teams and our within our facilities truly understand about what we're doing with the opioids and how important it is. We wanted to know pre and post survey if patients who were discharged on opioids receive information on where to dispose of unused opioids. So you can see that prior to this project, we had in the pre-survey a response rate of nearly 30% of the participants who were already providing education to patients being discharged. And I wonder if a part of that has to do with those that were in our first project. As I work with hospitals throughout Illinois, Iowa, and South Dakota, I find that that is something that's not done routinely. And even with my own hospitalization last winter, there was no information that was shared on where to dispose of opioids. So as you take a look then post-survey in that purple line, we see that 71% of participants now do provide patient education on where to dispose of unused opioids. So I think that's a big win for us. That's one step that we can take within our communities to assure that the opioids are not getting in the wrong hands. So about that community education, we wanted to know what did that look like? What were the participants in your community education meetings? And as you can tell here, the number one response was community members. And we can see that hospital staff was highly engaged, EMS, clinic staff, law enforcement, pain management specialists, and community pharmacists. Love to see long-term care staff who are engaged, and behavioral health. How awesome is that? I just want to let you know that in that other, which is in our number 2 ranking, some of those responses included some of the various strategies that were used to share within the community education about opioids. So some examples of that included holding internal as well as the community education that we're asking about here. There were some radio spots, some radio interviews. There were some community websites that they placed articles, hospital website articles, some community care transition teams and opioid task force teams were part of the other. And I have also wanted to talk a little bit about some focus on expanding that education again to elders. One really cool example that I am aware of is there were 4 students from Drake University, 2 were pharmacy students, and 2 were pre-med students. And they presented the Iowa Healthcare Collaborative's opioid education slide deck to a group at Edgewater Retirement Community, and that is in West Des Moines. They did that in the middle of May. It was a 1-hour presentation, and that when they presented that material to the residents in this facility, which is an assisted living facility, there were actually 14 residents who were present, and also 1 employee who was there from the facility. It was their lifestyle coordinator. And of the 14 residents who were there and participating in this learning, 3 were retired physicians and 1 was a retired physical therapist. So what I can tell you is they were highly engaged and had many questions. And so do not forget about our elders and the learning. And it's such a benefit for them, and what an opportunity for us to get the word out. So the question, which of the following entities are you collaborating with within your community about opioids, resulted in 84 of the participants collaborating with clinics. And then we have 64% with law enforcement, and nearly 60% with community pharmacists and EMS. So we like to see all of that. The other responses that aren't listed here include some focuses on some internal processes for collaboration, schools and teachers, and yes, elder issues. So very pleased about what we're seeing with the engagement in our collaboratives. We saw a 15% increase with the project participants for utilizing comfort resources with patients who do have pain. And so ultimately we can see that 80% of the hospitals utilize comfort resources for the patients that are receiving pain. So The comfort resources we're referring to are the IHC comfort resources, and most of you know what those are, but if there are some participants who don't, we're going to get into those a little bit. So then we had the question, implementation of the following comfort tools, and we asked that the respondents check those that apply. And actually, this was the one question that we had the lowest response rate. But as you take a look, the first one, the IHC comfort scale, and that was a big part of our project, we had just over 68% who did implement the comfort scale. And then we have the middle bar, which shows the implementation of the comfort menu. This one seemed a little bit easier for folks to get implemented. It was most often a team that took a look at what they could do to implement a comfort menu. It was individualized typically based on patient population, and there was a lot of sharing of resources within the participants on things that were working for them, the tools that were working for them, the why of that. So that was pretty interesting to see. The last piece is the comfort treatment plan. And we have just under 50%. So about 47% of our participants are utilizing the comfort treatment plan. And we have some nice tools in place. And I know some of our hospitals are still planning to implement this part of having a treatment plan. But this is also the key for when our patients leave the hospital. We had a lot of responses about implementation of comfort tools in the clinic. So that was the question, did you implement comfort tools in the clinic? And out of the respondents, we actually saw a higher percentage responding no. But keep in mind that we did have that comfort tool implementation within the clinic. And so let's just look at, even though we have a small group that did, let's see what they have to show us. So here's a clinic implementation of the comfort scale. We wanted to know what areas the comfort scale was implemented within the clinic. And so the responses were in specific areas of the clinic, pain clinics, and sorry about that typo there, and all patients. So the breakdown really is 50% in all three of these areas. So I thought that was interesting, just so we can see that the clinics were really trying some different things, and overall they were very much engaged in the comfort scale. Then we asked about the clinic and the comfort menu, and we saw basically the same distribution of results for implementation of the comfort menu in the clinic setting. So back to the comfort scale. We wanted to know specifically about the hospital. So our next questions in the survey do focus on hospital implementation of our comfort tools. This bar graph indicates the percentage of respondents utilizing the comfort scale in specific areas of the hospital. And so we wanted to know where. So you see Med-Surg is the highest area where the comfort scale was utilized and implemented, and so that's at 76%. There was a close to even distribution of the implementation within the emergency department, surgical / post-op, as well as obstetrics. And in the other areas of 35% responding to that, there were responses that included clinics in ortho, podiatry clinics, also in rehab. And I was very thankful to see that there was some implementation of the comfort scale within hospice and palliative care. What a great opportunity to assure quality focused comfort at the end of life. So I was very pleased about that. And so then we looked at the hospital areas that have implemented the comfort menu. Again, med-surg is at the top there, over 80%. Other was also in there, obstetrics, ED, and I was surprised hospice and palliative care wasn't a little bit more, just because what an easy area to implement that and to individualize that for patient engagement. So it's something to consider in the future. So this is question 24 in our survey, and the total respondents to question 24, in which of the following ways were clinicians using the comfort scale? And we asked that all be selected if they did apply to your facility. So we'll take a look, and we'll start at the bottom of the page. And that's where our highest response was. Over 90% of clinicians were asking or assessing patients about their comfort level regularly. So the emphasis being they were really promoting comfort in their assessment of the patients. And then the next three above that were running at 85%. The comfort scale was reviewed post-operatively. It was included in patient admission information, or it was hung, the scale was actually hung in each patient or clinic room. Again, that was at 85%. I liked this one, reviewing it prior to surgery, which was 77%. That's a great opportunity to set those goals for comfort and to come up with a comfort plan with the patient prior to surgery. And then the other of 30% was including clinics. Some even asked the patients to bring their comfort scale with them for each return visit. And I thought that was interesting, because there's an opportunity for them to really track that and to bring that back for ongoing assessment of the prescribing provider to determine if opioids were needed to be continued or dosing per MME. And so I thought that was pretty positive as well. Some use the comfort scale in conjunction with the comfort menu, and that was discussed at bedside reporting with patient engagement. So again, those are great opportunities in those other categories. So how did the comfort scale get used within the hospital setting? So in addition to the pain scale as an adjunct tool was 40%. That's one of the pieces that we found, was that it was more difficult for some hospitals than others to transition away from the old pain scale. And 35% said in place of the pain scale, while we had hospitals who said they did not implement the use of the comfort scale. So again, that was one of our biggest struggles, but it's information that we needed to glean to find out what we can do to promote the comfort scale. So we were really interested in what the feedback of clinicians was on implementing the comfort scale. And you can see here what we learned from the respondents was that 91% of the time, or the respondents, excuse me, on average report clinicians and practitioners report no change in time per patient in utilization of the comfort scale. And there was just a small incremental group there that said that there was an increased time per patient for the clinicians and practitioners for the comfort scale. So I can see where there might be that small piece, especially I would say if you had patients who were so used to using the pain scale instead of the comfort. So that change in that might take a little bit longer just to do an overview of the comfort scale. So now just changing our focus to legalities. we can see that there was improvement in our post-survey response to the question, is your healthcare team aware of legal implications involved around prescribing opioids? So we moved from 76% answering yes in the pre-survey to 92% in our post-survey. So ultimately, there was more training about that. We had the webinar on legal implications. So it is still there and available if it hasn't been reviewed within your healthcare team. Also in the pre-survey, nearly half of our hospitals responding were unsure if providers were registered for and using the prescription monitoring program, or what we refer to as the PMP. And now we can show that over 90% of our hospitals have half or more of their providers who are taking a look at the PMP and registered for the PMP and using the PMP. And so it's nice to see the jump in the 76 to 100% tile with the purple in the post-survey. I think we know that legislatively there's changes that are occurring with the requirement of the PMP. And I had someone ask me a bit about the monitoring of the use of PMP, and my response to that was, I know that that is being looked at, and I saw that there's some additional jobs posted. I think there were 2 or 3 last week, and the focus on those state jobs was specifically to the PMP, excuse me. And so I do think they're working on a plan for monitoring registration as well as the use of the PMP. So this will be the next set that we go through, which is going to take a look at some of the Compass Hand specific data results. So a Compass Hand opioid report was developed to look in detail at the coding for opioids within our HIN. This chart is demonstrating results related to the Compass Hand top primary ICD codes. And these are the opioid-related diagnoses used most frequently as a primary diagnosis. So we have the data dictionary, and using that, in parentheses, you'll see CH 1.01. And the definition is the top primary opioid diagnosis by ICD-10 code. So the table here displays the specific ICD code in that first column. The second column is the count of the corresponding diagnoses. And then the third column is the ICD-10 descriptive diagnoses. So when we utilize the ICD-10 code document, it just helps us in understanding our reports, what those definitions are, how the coding is listed. And as we're taking a look at this document, it demonstrates the ICD-10 code document. I apologize, I don't have it up. But that document demonstrates 2 different coding breakdowns within the ICD coding. And when we look here at this table, we can see a highlighted cell. So in that ICD code document, any highlighted cell indicates opioid abuse. And any non-highlighted cell indicates opioid poisoning. So those are the 2 pieces that were looked at for our data. And so those, again, that ICD code listing was sent out. And so in this one, we can see within our Compass HIN for the overview period of January 2016 through December 2017, the #1 top primary ICD-10 code was T401X1A. There were 356 diagnoses of poisoning by heroin, accidental and unintentional, and it was their initial encounter. You can see that's one of the highest diagnoses within the HIN for the time period. The number 2 was poisoning by other opioids, which was accidental and unintentional in the initial encounter. The third one is poisoning by other opioids. This was intentional self-harm, and it was an initial encounter. At 130, there was poisoning by unspecified narcotics. It was accidental, unintentional, and it was, again, the initial encounter. And then the one that is highlighted, this one again, the highlighted cells indicates opioid abuse versus opioid poisoning for the others. So this one shows 117, opioid dependence, uncomplicated. Now, for those of you in the coding world, this is kind of a generic code that often happens, but it is what we saw within our Compass HIN. And then lastly, the last one at 105 count, poisoning by other synthetic narcotics, accidental, unintentional, and then the initial encounter. So I think these are some key things that we can take away from that when we're taking a look at some of those initial encounters. We have that 1, 2, 3, 4, 5 out of the 6 times. So I think we just need to watch this and see where it takes us, but we'll be watching overall within our HIN. Now this next slide is going to show us a little bit more detail of opioid abuse or opioid poisoning. And so it's showing what we saw on the other previous slide. It just provides us with a visual comparative of abuse versus poisoning. And so opioid abuse is in that dark green line versus the opioid poisoning in the lighter green. Again, this is from the HIN overview report, so all of the Compass HIN hospitals. What it's showing us is a demonstration of a 2-year period, and we're seeing a trend upward very steadily in opioid abuse, where opioid poisoning, really we're not seeing that same trend. It's almost running at 0, but we can see maybe it is going up slightly, but that's when we'd want to watch. Essentially, we just need to track this information and watch for that upward, downward fluctuation and utilize the findings to prioritize the work that we're doing here with IHC for our HIN hospitals. So these are some things we'll be watching for the Compass HIN overview report. In this opioid overview report for our Compass HIN, there was a section that was specific to heroin. So as you take a look at this first graph on the left, you can see that heroin is on the rise. And I'm showing it to you to represent the significance in heroin use, as a line graph shows heroin more than tripled within Iowa hospitals per the ICD coding between January of 2016 through December of 2017. We know we're not in the height of the epidemic, but we can see that there is rise within heroin use. The second pie chart here, it depicts the percentage of heroin prevalence on admission, and so it's designating weekday or weekend. So the ICD-10 code that was used identified unique patients just by record ID, so we could take a look at when they were admitted. So again, 60% in the blue were admitted with heroin coding on weekdays versus 40% that were admitted on the weekend. And yes, so these are just some tools that we can use to watch what's trending within our Compass HIN hospitals. We took a look at Narcan use in the community setting prior to admission. This is one of our ADE measures. So as we take a look at this data slide, the black is indicating all Compass Hen hospitals, and then the golden yellow includes the hospitals who are participating in the current opioid guardianship project. So essentially, we see the trend is consistent between the two, with only a slightly higher rate with the project participants. So ultimately, there's no statistical significance to this information, but we are able to take a look at what was happening within the prevalence of Narcan use in the community. So I think it's good for us to keep monitoring what's happening in our communities prior to admission. And then comparing the opioid cohort to all Compass Hen hospitals, the emergency department administration of Narcan does show some increase based on the trend line. And so what's interesting here is it's pretty equal for what we're seeing with all the Compass Hen hospitals versus the opioid cohort, and both are trending upward. But I think our cohort is just slightly below, as you see, the all Compass Hen hospitals. I think one of the things is to know is when I last checked, there were only about 60% of our Hen hospitals that were actually reporting emergency department administration of Narcan. And so one hypothesis may be that the more hospitals that start their opioid stewardship programs and start actually reporting emergency department naloxone use, that we would expect to see some incremental increases with their project implementation. So I think it'll be interesting once we know we get all the Hen hospitals engaged in tracking Narcan use in the emergency department, kind of what we're doing. And I think it's going to help us not only individually at the hospital, looking at what's happening within your ED, but also within our Compass Hen. So I really kind of look at the period now that we're looking at as baseline data, and probably even the next 6 months. But I'm going to really try to encourage all hospitals start to report the Narcan administration in the emergency department. So you'll be hearing more about that if you're not already doing so. I wanted to take a little deeper dive into the use of Narcan in the emergency department. And so right here, this last quarter of January through March of 18, it's basically about 65 to 70 hospitals that have been reporting that. And you can see this is just depicting the total number of hospitals that are reporting, and it is climbing upward. So again, hence the trends for upward. So, it's just important that we get this baseline data. I said it before, since we know the epidemic for Iowa truly isn't anticipated for about another 4 years. And so we want to really promote the increased awareness for each hospital, watch those trends, and identify strategies that'll be appropriate for implementation when you see something really happening in your community, in your ED. So Narcan use outside of the emergency department measure, this reflects essentially the inpatient setting of your hospital. And the numerator in this measure is the number of episodes that a reversal agent is used, whether it's acute care, skilled, swing, beds, and observation. And that's with the patients who are prescribed opioids over the denominator, which is the number of patients prescribed opioids. So we can review the data here. We see a steady decline in the inpatient setting. I'm going to just say you can see it too, but there's a lower amount with the opioid cohort. Is that in part due to the enhanced awareness with our opioid education? I think we're just going to need to continue to monitor the inpatient Narcan use as more hospitals do initiate the opioid stewardship programs in their hospitals and get that education out. With this, a lot of times when I see some high-performing hospitals, what the number one takeaway from those high performers is for inpatient Narcan use is, bottom line, it is kind of a standardized prescribing format, less is best mentality. So that's what I'm seeing. So the opioid therapy treatment plan is showing some steady increase from the initial opioid guardianship program that was last year, July 2017 through December 17. And this is one of the targeted goals that we have for the opioid guardianship projects. So we're going to want to continue to monitor the measure, as many of the current project participants indicated now that they don't have it going yet, but if they don't, they're planning to get that implemented. So that's a good thing. And we can see how the trend is going up. And I thought I'd just review real quick what this measure is really about for those that aren't that familiar with it. So know that the numerator on this one is the number of patients who are discharged from the hospital who are on opioids and who have patient-specific goals of therapy at discharge. So then the denominator is just the number of patients who are discharged on opioids. The big thing here is the tools that IHC has developed and are available to you is using the Comfort Treatment Plan tool. It's there, it's available, it prompts you to assist in assuring patient goals are identified prior to discharge. It's easy to track and trend whether or not one is in place or not based on charting. But this is a big key for us in our project works within our HIN to really make sure that we have a individualized therapy treatment plan for each patient discharging on opioids. So highly, highly recommend that you take a closer look at that and come up with a plan on getting that in place. So this is a translational research study, and what it's looking at is the impact of the comfort scale on opioid prescribing, and there's going to be some data review conducted with IHC and Drake University. Sarah Durr has been working with Drake faculty and some students who are assisting in the review of our data. There will be 4 data measures and the surveys that will that were provided to our participants that will inform this study. And so IHC may be requesting some success stories from you, participants, to help us in that qualitative writings for the study. And the ultimate goal is to publish study findings. So as I said earlier, when we get to the point where there is something published, that will be shared within our hospital network. Take a look here to see if there's anything in our chat. So just again, just encouraging you, if you have any thoughts or questions or comments, please go ahead and put something here in the chat and we will take a look at it. Okay, what's next? We always talk about sustainability, don't we? Well, let's make this real today. So the number one thing with this project and any of our performance projects that are going to be working and sustainable is that we first and foremost recognize the patient and or the family engagement portion of all the work we're doing, and specifically with our opioid works. As we think about the comfort tools that we provided from the Healthcare Collaborative, We identify about how each tool does engage the patient to think about their comfort. What is their comfort level? To frame their evaluation around comfort versus pain. And then the tools, all of them, also allow patients to identify their level of comfort, have the opportunity to choose from a menu of items, as well as assuring that there's a patient-centeredness component when we're working with our patients by individualizing their choices. What works for you? What's best for you? What can we add to your comfort menu to ultimately achieve the patient-identified comfort goals? The comfort treatment plan, it really serves to promote actionable comfort goals. It helps patient and families understand about what the medications are that they're taking home. It's not that we don't do the education, but we're really focused on if this is an opioid and what it is and what it means. So in addition to the routine patient teaching around medication safety and side effects, we're talking about the opioid. How do you dispose of the unused medication? And from the treatment plan, some of our hospitals have identified and used from discharge to provider just follow-up care. So bring your plan, your menu, comfort menu with you. After you leave the hospital, your primary provider wants you to bring that. So at that next clinic visit, we're asking, is this still working? We can modify that comfort menu and really personalize it for that patient. So, I think our goal here is to promote the patient engagement within their healthcare. And what these tools do is it really does promote questions, and it promotes a two-way dialogue for opioid safety and the knowledge that people need for that. So I think all of the tools really do promote patient-family centeredness, just for that full engagement. Again, making sure that that patient is a member of their own health team. It is their health. It is their team. They should be in charge. The opioid stewardship work is going to continue in our hospitals, clinics, and communities. And so your participation in this project really has benefited already your local community with all the efforts you've been working on. We will see benefits throughout the Compass HIN states that are currently participating and those that jump on board. We've spent some time on learning how upstream prevention and appropriate prescribing are paramount to the opioid stewardship works. Having the right group on board within your facility, the board and administrative and practitioner level engagement, acceptance and approval and support are where the bottom line starts. And we've heard from experts on addiction treatment and relapse prevention, as well as heard from HIN hospitals on various activities they've done to promote this pillar within their communities. We've spent a lot of time with much learning about diversion prevention, medication disposal, and we've been engaging our hospitals and community clinicians to promote the best practices. So these are the things that we've been working on. These are the things we'll need to continue. So as we take a look at upstream prevention, what are some things that we can do? We've talked about how it's important to standardize your approaches to pain management, utilizing the comfort scale, utilizing the comfort menu, having opioid therapy treatment plans, and establishing stop dates for opioids. That's one of the key pieces within your team, within your patient's team. And then utilize controlled substance agreements if that's necessary. Those are documented, those are included in the health record, those are shared between hospital, clinic, and other providers. So that's a great way for upstream prevention. And then for appropriate prescribing, we know the prescription monitoring program needs to be used. It is being mandated. There are different methods that people have shared within the project on how they're going to monitor that. but also know that it appears it's going to be monitored at the state level as well. And then opioid prescription protocols. And we spent some time talking about chronic versus acute pain management. We've had some great speakers, from pharmacists to mental health professionals to pain specialists, talk about making sure that we are individualizing pain control for our people, making sure their comfort is set with their established goals, and prescribing appropriately, utilizing morphine milligram equivalents. So addiction treatment and relapse prevention. We've spent time throughout this process of this project talking about appropriate referrals. And so we list a couple here: pain management clinics, mental health clinics. Let's not forget about physical therapy and some of those other comfort kinds of things that can be done. Maybe it's massage, physical therapy can be engaged. Could occupational health help us? So think about those. And then utilization of medication-assisted treatment programs. And I'm hopeful that we'll see more come to light throughout our Compass Hen hospital network. In diversion prevention, medication disposal, again, standardizing using accountability agreements, what we refer to sometimes as pain agreements, prescribing practices, getting providers to take a look at how that prescribing should be, limiting medication refills, those community efforts to coordinate on the community level, what it is that we need to do to assure that prescriptions are disposed of, which is our next section, medication disposal. So just keep that at the forefront with our communities. We want to make sure our medication disposal sites are advertised within our community with education on the why, as well as with patients, whether they're coming through clinics or hospitals and discharge, but promoting best practices just so we prevent medications from getting in the wrong hands and to prevent opioid overdosing. So what are our next steps? Depending on where each hospital was with this rapid improvement project, we did see different responses and next steps that were being planned to utilize the comfort resources. So with that in mind, we can see that there are responses here listed that ranged from engaging physicians in the use of comfort plans to including support. We wanted them to support us, the use, in conjunction with the opioid prescribing. There were 4 active hospitals who couldn't have their community meeting during the course of the project, but they have those scheduled for this summer. And so that's a great thing. Many responding included how they wanted to expand the use of the comfort tools and continue to expand education on the opioids further throughout their hospital, within their clinics, as well as the community setting. And I think the key point here was inclusive of all support staff. I saw that quite a bit, and to include all staff. So love the way that thinking is, and that's what it's going to take to get our Army together for the opioid crisis. Hospitals sharing did occur with the post-survey responses, and it included some specific plans to advance the works within the opioid stewardship projects. Examples did include to continue with the opioid community and/or task force involvement, to continue education within the community on opioids. And I would really encourage you that if you don't have an active opioid task force within your community, that you seek out partners locally to join forces and promote collaboration and approaches that can best fit your community needs. When I say community, I just want to stress, when I talk about that with a task force for opioids, it can be kind of a district. It doesn't just have to be your small little town or just your city. So just consider looking outside at what resources there are to have an opportunity for task force involvement. And then lastly, we just ask that you really track what it is, the work that you're doing on opioids, specifically to note the strengths of what it is that you're doing, as well as identifying opportunities to continually improve. This will be a way for us to share with one another and to share with other healthcare providers. Thus, ultimately, we can share our best practices within our HIN states of South Dakota, Iowa, and Illinois. I have a couple more slides. This one, in some early discussions have been occurring about the provision of an opioid webinar sometime in early fall to engage all of our HIN hospitals. The initial brainstorming has been around the opioid project and participant sharing of best practices and lessons learned. The webinar could also be an opportunity to provide ongoing support to hospitals who have participated in the project. And if you have thoughts, comments, or suggestions, please let me or another member of the HIN team know how we can best meet your needs around opioid stewardship. And with that, on our Q&A call Tuesday this week, I did share about the Iowa Healthcare Collaborative's TCPI opioid presentation. It is in person. It's a live event. It's in West Des Moines. It's on the website. It's an all-day event, and it looks amazing. So we just want to make sure you're aware of that so we can get the word out and bring your clinics. It is for that clinic base, but it's for all healthcare providers. Let me take a look, see if we have any questions, any comments. I really just want to take the opportunity again to thank you all for participating in the project. Your work has helped our patients with pain, and it's turned, in turn, it's really reduced the amount of opioids that are currently being prescribed. We have many of you who are tracking that within your hospitals, and that's pretty exciting. If you have any comments, any questions, always feel free to reach out to Sarah Durr, our medication management pharmacist here at the Iowa Healthcare Collaborative. You can reach out to me or any of the clinical quality consultants here at the Iowa Healthcare Collaborative in our HIN. And I think we'll be working more and more with hospitals one-on-one on opioid stewardship projects. But until we decide how we're going to move forward with any further webinars, that's what you can expect. I'm going to take a look and see if anybody has their hand up or if anybody has any comments for us as we are getting close to ending our presentation today. And there are none, so I would like to say thank you so much, and we will end our call now. Keep up the good work, keep working hard. Know we're in this together, and I can't wait to share future data with you. Thank you so much again. Goodbye, everyone.